Welcome back. I'm Dr. Devi Nair, live from St. Bernard's Medical Center in Jonesboro, Arkansas. Session 2 is a presentation session on risk reduction with arrhythmia management. I'm again joined by my esteemed panelist, Dr. Julian Chun from Marcus Krankenhaus am Main in Frankfurt, Germany, and Matthias Dorschauer from St. Jane Hospital in Bruges, Belgium. And I'm delighted to welcome the session presenter, Dr. Carina Bromström Lundqvist from Sweden. I'd like to remind you, delegates, to keep submitting those questions around the topic, and we'll try to answer as many questions as we can during the session. For now, Carina, it's over to you.
Hello, everybody, and welcome again. It will be a pleasure for me to discuss with you risk reduction with arrhythmia management. Here are my disclosures. We all know that the lifetime risk of AF increases with age and also with a number of risk factors, as you see on the left side of the slides. Now, AF is a cardiovascular disease, and there is also a risk of increased mortality, stroke, heart failure, dementia, and decreased quality of life, leading to increased hospitalization rates. So the question is, can arrhythmia management change AF-related outcomes? We know from rhythm control studies that rhythm control improves outcomes in patients with AF if provided early enough. We know that from the EAST AFNet trial, showing a reduction of cardiovascular death, stroke, heart failure, and acute coronary syndrome at 5 years follow-up as compared to usual care. We know it also from the Athena trial with using dronedarone as compared to placebo. So the question is, what will happen if we modify the risk factors? We have some key risk factors for AF development, which includes congestive heart failure, age, as we've already discussed, valvular heart disease, hypertension, diabetes, and myocardial infarction, as shown here from the Framingham study. Now, we also know that BMI, obesity, and an increased left atrial volume results in AF progression, and together they increase the risk for AF progression substantially. Now, the mechanism. Let's look then at the experimental model studying sheep, how obesity promotes cardiac structural changes resulting in progressive slowing of atrial conduction. We can see that obesity results in increased left atrial volume, pericardial fat. It results in a decreased conduction velocity. And in this sheep model, with increasing obesity, we have an increased number of AF episodes, and also once in AF, the AF duration increases with increased obesity. Looking at the clinical trials, we have a randomized clinical trial evaluating the effect of weight reduction and cardiometabolic risk factor management. Patients were randomized between risk factor modification and control arm. And with BMI reduction, there was also a decrease of AF episodes, number of AF episodes, the cumulative AF duration, and the left atrial areas decreased. From the same study, 87 out of these 248 patients underwent MRI, and it could also be shown that the left atrial end diastolic volume decreased in the intervention arm, and the pericardial adipose tissue, which promote inflammation, also decreased, supporting the experimental findings. The Arrest AF cohort study is the first randomized trial evaluating risk factor modification as compared to control. Now, you may criticize the randomization because the patients belonging to the control arm were actually those who did not want to undergo risk factor modification. The risk factor management arm included a weight management, control of hyperlipidemia, glucose tolerance, hypertension, and sleep apnea management. Patients were checked every 3 to 6 months clinically and using 7-day halters. They were also evaluated with regard to quality of life using the AFSS score system. And as we can see, in this study, AF ablation, the outcome of AF ablation improved by 30%, comparing the control arm as compared to the intervention arm after a single procedure. And after multiple procedures, the AF-free survival was significantly higher. We can also see that the burden score was much higher in the intervention arm as compared to the control group. And the global well-being score was higher in the intervention arm as compared to the control arm. A later trial, the Legacy trial, also studied the long-term effect of the goal-directed weight management. Patients were followed for 5 years, 355 patients included. The BMI was over 27 kilo per meter square. And if we look at the group of patients not undergoing any rhythm control, it was a much better outcome, freedom from AF in 45%, in those who had a larger weight reduction, over 10%, as compared to the other groups with a lower weight reduction, 3 to 9 or less than 3%. To the right, we can see the outcome in patients also undergoing rhythm control therapy, antiarrhythmic drugs, and ablation. An important observation was that the outcome was much improved if the weight fluctuation was small. So 85% of the patients were free from AF after 5 years if the weight fluctuations were less than 2%, as compared to 44% of freedom from AF if the weight fluctuations were above 5%. Now, the reverse AF study is part of the Legacy trial. Again, 355 patients. And what we did in this study was to look at the AF progression and AF reversal in the 3 subgroup of patients losing weight less than 3%, 3 to 9%, and above 10%. And as you can see, patients who managed to go to have a weight reduction above 10% had a much better outcome with regard to progression, much less progression in these patients as compared to those only losing 3% of weight. The opposite pattern was observed with regard to AF reversion. We have a meta-analysis including 548 patients and including the 5 randomized or cohort studies comparing risk factor modification, and they divided the 2 groups in those losing over 10% of the weights and the other groups losing less than 10% of the weight. And we can see that the group that lost over 10% of the weight had a better outcome with regard to the risk for AF recurrences, as we can see on this forest plot. They also looked at the event frequency score, and the episode duration score, which was in favor in those with high weight loss, over 10%, as you can see. Looking at the global episode severity score and the symptom severity score, which was also in favor for the group losing over 10% of the weight. Now, these 5 trials were subject to bias. This analysis was performed and looked at the bias, and we could see that for the selection of patient bias was quite high. It was only the trial by the ABED that had no bias. So this is a problem with these trials. This recently published review of randomized trials looking at the different risk factors, we can see that the lowering of blood pressure is associated with a reduction of AF recurrence. And this is the ABED trial also showing that weight reduction is associated with a decrease of AF recurrences and burden. One randomized trial aiming at blood pressure reduction showed no difference with regard to AF recurrences. And here we have the trial by Rienstra. It's the RAISE-3 trial showing that medication optimization and dietary changes was indeed associated with improved rhythm, with higher frequency of sinus rhythm in the intervention arm. So based on all these trials, the AF guidelines recommend identification and management of risk factors and concomitant diseases, modification of unhealthy lifestyle and targeted therapy of anti-current conditions, and weight loss in obese patients who are undergoing AF ablation. It's a class 1 indication. And of course, the lowering of blood pressure is also a class 1 indication, whereas weight loss in the general AF population, avoiding alcohol excess and promoting physical activity is a class 2A recommendation. And at the time when the guidelines were written, treatment and management of obstructive sleep apnea was classified a 2B recommendation. So what happened after the guidelines were published? We have the first trial looking at the effect of continuous positive airway pressure on arrhythmia in AF patients with sleep apnea. This study included 109 paroxysmal AF patients referred for AF ablation, and they had moderate to severe sleep apnea. They were randomized to CPAP or usual care, followed for 5 months before ablation. AF burden as measured as % of time in AF by a loop recorder, evaluated at baseline for 1 month and the last 3 months of the intervention period. And unfortunately, there was no difference in AF burden, nor in quality of life or daytime sleepiness in CPAP patients versus those receiving usual care. There is one study published on weight reduction, the SORT AF trial published this year. Patients undergoing structured weight reduction, 142 patients, underwent first AF ablation and then weight reduction or usual care. Patients were included if they had a BMI above 30. Followed for 12 months. They had an implantable loop recorder and sleep apnea screening and treatment. So at follow-up, 12 months follow-up, we had a significant reduction of body mass index in the intervention arm as compared to the control arm. If we look at the AF burden, which was the primary endpoint, there was no significant difference between the intervention arm and the control arm after 12 months. If we look at the AF recurrence-free survival, there was no significant difference between the intervention arm and the control arm after single procedure and multiple procedure AF ablation. But if the data were analyzed in patients with persistent AF, there was a much higher AF survival-free outcome in patients losing -5 BMI. So we can conclude our key message is identification and management of risk factors and concomitant diseases should be an integral part of the treatment of AF patients as concluded in the AF guidelines. Key message 2, recommendations beyond AF suppression are limited or even lacking. We need well-designed randomized trials of lifestyle and risk factor interventions in AF, and this is an important knowledge gap still. Thank you very much for your attention.
Thanks, Karina, for a great presentation on such an important topic. Dheeraj showed us a great case, but I don't think we can get those results if we don't start it right. So you've definitely shown us great data on risk, on the importance of risk factor modification. And I understand there's knowledge gaps, but I have a very practical question, and I know we all need to do this, but what is a practical way of bringing in a multidisciplinary team that can help us take care of our AF patients? I think it's important for us to shed some light to our audience about how each of us does this, because AF is such a chronic condition and such an important disease that we need more help than just an EP.
Well, I think it's important that we have a close contact with the primary care physicians and also with nurses that can discuss with patients with a lifestyle modification program. That is one important part. And I think we should screen patients before putting them on the table for AF ablation.
Yeah, I thank you, Karina, for this excellent presentation and beautiful overview about the current data. And I think we all agree that an obese patient, of course, should optimize the personal and individual risk factors, including losing weight and being active, etc. But in many patient or in many physicians' experience, it is super hard to motivate those patients to really adhere to those recommendations, and they still are often complaining, yeah, I would like to do sports, but I can't because I have this arrhythmia. So therefore, it is in both ways, it may become a difficult situation. And therefore, I think if we still may consider of doing a catheter ablation procedure in those situations, safety again is super important, and in this situation here, for me at least, it would be safety with regards to not creating a tamponade. What are your opinion or your thoughts regarding that?
Well, I agree that the safety has been proven safe even if you are obese. Let's exclude the extreme ones, of course. But at the same time, I think it's important to sort of try to have the patients lose weight. Even though I realized that regarding the last trial I presented, the SORT AF trial, despite referring patient to such an obesity clinic, they didn't manage to lose that much weight. It only corresponded to, I think, 3% of weight reduction, which may explain why the trial came out negative as compared to the Arrest AF trial, from Australia.
I think from a practical standpoint, you have to bring the patient back into the loop and make them in charge of their health as well a little bit, because I think we are taking the risk of putting the patient on the table and going through it is an invasive procedure despite the technology. So I think if the patient does show an inclination to lose weight and maybe they don't meet a goal weight, but at least they go in the right direction, I think it's a reasonable step to bring the patient to the lab as long as they stay on path. But I was really thrilled by looking at the data on the weight, the fluctuations in the weight and how that correlated with the efficacy. So any thoughts on what what you consider is okay, and what are your how do you take care of that with your patient population?
Oh, that's a difficult question. I would refer the patients to a professional obesity clinic or something, or primary care. I don't think we as electrophysiologists have the time or sort of competence to deal with these kind of issues. I admire the Australian group for being able to pursue such a good program for the patients.
Yeah. Matthias, how is it in Bruges?
Well, I think it's everywhere the same. We've been ablating for many years, and I think we are quite motivational speakers also when we speak to our patients. And at the end of the day, what happens is that we end up with the 3% weight reduction like in the SORT-AF trial. So regardless of its negative findings, I think it is the reality so far. I think we have to sit down all together and then discuss whether we need a kind of obligation to lose weight rather than a recommendation, because it won't work the way we're doing it right now. It's too difficult. And the two randomized trial, also the one with the correction for the sleep apnea that is negative, is in the same direction. Also there, the patient it wasn't probably enough what we did in those patients. So reality versus Australia data.
That's funny. Yeah, I like that.
I think Precious. Go ahead, Julian. This is your turn now.
Sorry, just very briefly, we have been retrospectively looking into 600 patients we called obese, and we treated with a cryoballoon. And what we found is that until a BMI of 34, the outcome was very similar to those not being obese. Beyond 35, the outcome was worse. And this is why we still sort of also, we try to do both. We try to engage the patient to change lifestyle, but also we would offer, we would not definitely, let's say, not offer those patients an AF ablation procedure, because it can be mutually motivating as well. And the data, at least with the cryoballoon, is super safe with regards to tamponade, and it is comparable.
Do you have an upper barrier?
The finding was beyond 35, outcome was worse than below 35. Above 35, it's a super individualized base. So we do set, of course, nobody is asking for somebody with that BMI on a table, but individualized decisions.
I think one has to wonder the role of these comprehensive AF clinics, bringing all these multidisciplinary folks into one building where the patient doesn't have to go see multiple centers or multiple providers, and just bringing everybody into one center, and how that will pan out. And there's a lot of data on these comprehensive AF clinics coming out with good outcomes like Australia has. Having said that, I think we are running out of time for this session. I'd again like to thank our panel and our fantastic presenter. Thank you, Karina, again, and thank you, Julian and Matthias. We have got loads more still to come on this first day of Rio 2021. But now let's have a short break from the main program. We do have symposia and breakouts starting very shortly, so please check those out. We'll see you all a little later for session 3. It's a cryoballoon case with none other than Julian Chan, chaired by Jason Andrade at this time. And so see you there. Please make sure that you go and visit the breakouts and join us for session 3. Thank you.
Bye.
Bye-bye. Thank you.
See ya.